Good afternoon, and welcome to today's IAC webinar, Echocardiographic Assessment of Diastolic Function. My name is Kelly Bear, and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation, and we'll try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click on this tab for links to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during the course of this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASE CEU credit, you must be registered, logged into this webinar, then complete the survey. The survey will open automatically at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I would like to introduce today's guest presenter, Dr. Mary Bramer. Mary is the Quality Improvement Education Coordinator at the Mayo Clinic Echocardiography Lab in Rochester, Minnesota, and holds an academic appointment as Assistant Professor of Medicine at the Mayo Clinic College of Medicine. She is board certified as a registered nurse and holds the RDCS credential from ARDMS. In 2015, she became a credentialed advanced cardiovascular sonographer and completed a doctoral degree in educational leadership. She serves on the IAC Board of Directors as well as the IAC Echo Board of Directors representing SDMS and is a fellow of the ASE. During the past 15 years, Mary has lectured nationally on a variety of echocardiographic topics, sonographer ergonomics, and quality assurance. With that said, I will now turn this webinar over to today's speaker, Mary Bramer. Mary?
Thank you so much, Kelly, and welcome, everyone. I'm hoping that the next hour or so will be very helpful to you. First of all, I have no disclosures, and we do have a couple of poll questions, however, that I would like to start with. My intent is to ask these questions now, and then we'll ask them again at the end of the presentation so we can see how much you learned during this hour. So the first poll question, myocardial relaxation is abnormal in all patients with diastolic dysfunction. True or false? And part of my reason for asking this question is because I want to get to the very bottom of what diastolic dysfunction is about.
So, Mary, the poll results are in, and 57% of the audience says that was true, and 42% say it was false.
Okay, thank you. Let's remember those numbers. I have one more question for you. Myocardial stiffness results in what change in filling pressure? Does filling pressure increase, decrease, or is there no change in filling pressure with increased myocardial stiffness? While you're doing that, I want to thank you again for spending some time with us today. The reason that we are really focusing on diastolic function will become very clear in just a few moments when we talk about the new revisions to the IAC standards.
So the results are in, Mary, and 73% of the audience say increased, 24% said decreased, and 2% said no change. Okay,
so that's where we're starting. Let's move on. So what I want to do during this webinar is to just very briefly review the phases of diastole. The bulk of the discussion will be talking about technical tips for echo assessment of diastolic function, and then also we will discuss diastolic function assessment as detailed in the 2016 ASE Diastolic Function Guidelines. So the new IAC Echo standard for transthoracic that many of you should have seen already is that diastolic function evaluation is now a required part of a transthoracic echocardiogram. And the standard states that LV diastolic function must be evaluated through a combination of pulsed wave and tissue Doppler techniques. Just how far you go is up to the lab. The requirement is that there has to be some element of pulse wave Doppler and tissue Doppler. In addition to that, you need to report on the diastolic function. The report text must include comments on the left ventricle. These other things have already been established, the LV size, EF, regionals, and diastolic function, so that's the new piece. And near the end of this webinar, we'll talk about how to report diastolic function, as well as spending the bulk of this webinar talking about how to evaluate it. So, your new best friends. We have a couple of diastolic function guidelines that ASE has published, and I find them very, very helpful both in my practice as well as when I'm teaching. In 2009, we had the original recommendations for the evaluation of left ventricular diastolic function by echo, and then in 2016, we had an update from the ASE and the European Association of Cardiovascular Imaging. Both documents are very, very helpful. In particular, the 2016 document comes with some bonuses. If you go to the ASE website and look under guidelines and the guidelines search, you can search for diastolic, and that will bring up this document. As a bonus, there's actually a webinar recording that Dr. Sharif Naga did that can help explain more of the document. And it really, honestly, will get into some of the deep things regarding diastolic dysfunction that we won't be addressing today. So it's very nicely complementary to what I'll be covering. The document also has some very, very helpful guidelines. There are tables, the first of which that I'd like to bring to your attention talks about different two-dimensional and Doppler methods for assessment of diastolic function. It outlines the variable, it details how to acquire it, and then also it has tips for analysis. So please refer to this document. Many of the things that I'll be presenting today have been pulled from this. There's also another table that talks about the utility, advantages, and limitations of the variables used to assess LV diastolic function. For instance, the mitral E velocity, the utility is explained, advantages, and limitations. I'm sure you figured out by now that diastolic function is not exactly an easy thing to evaluate. So again, this document is very, very helpful as you try to do that for your patients. So let's talk about cardiac function. Systole and diastole, pretty basic, we think. Systole is the pumping portion of the cardiac cycle. Diastole is the filling portion. And when we talk about normal diastolic function, all we're really saying is that the heart is able to adequately fill without excessive increase in diastolic filling pressure, both at rest and with stress. So that's the definition of normal diastolic function. Going over the filling portion of the cardiac cycle for just a little bit, I would point toward this cath curve. We have the LV pressure tracing and the LA pressure tracing, and then we have the mitral inflow here. So we're looking at diastole, looking at the portion where we have a gradient that allows filling and is reflected in the mitral inflow. So the first thing that happens during initial passive filling is that an LV-LA gradient exists, which pushes blood into the left ventricle. Also, there's rapid relaxation, and so there is a suction effect that pulls blood into the left ventricle. That's during early diastole. Then you do have a small rise in the left ventricular pressure, and that's when you have a very compliant ventricle. Atrial contraction is the later part of diastole, and we have a small gradient there, and that is the A wave on the mitral inflow. Now, when we talk about diastolic function, there's two ways to look at it, and this is simplifying it a lot. We have a healthy pull here, where the ventricle is able to just pull that blood in, or there's a very laborious push, and this is what we're dealing with when we get into diastolic dysfunction. So let's look at progression of diastolic dysfunction, looking at transmitral gradients versus the mitral inflow. Now here we have our normal mitral inflow and normal cath curves. Excuse me just a moment. We'll go ahead and get this animation started. We move into abnormal relaxation, and I'll stop that for just a second. So we're seeing the very characteristic grade 1 of 4 diastolic dysfunction, or the abnormal relaxation pattern. And what's happened here is that we have delayed relaxation. Let's go ahead and take a look at this LV pressure tracing here. See how it's so quick in the normal function, and see how it's delayed here. So we have impaired or delayed relaxation. However, the filling pressures are still normal in this phase. So let's go ahead and continue on down the road of diastolic dysfunction. And we get to where we see the restrictive type pattern in the mitral inflow. And what's happened now is that the ventricle, the compliance has decreased, and the ventricle is no longer able to fill as well as it used to without excessively increasing the filling pressures. So let's start there and take a look at the table that's provided in the diastolic function document that just goes over normal, grade 1, grade 2, and grade 3. And this is just a nice little summary of the things that you would expect to see with each of those grades of diastolic dysfunction. I'd like to boil it down to even more simple things. And this is in my little book of what's really important to know. First of all, you need to know that myocardial relaxation is abnormal in all patients with diastolic dysfunction. If you remember the little animation that we just saw, with normal relaxation, we have very quick initial diastolic filling. But once you move to grade 1 diastolic dysfunction, you have delayed myocardial relaxation. So it doesn't matter what grade of diastolic dysfunction you're in, myocardial relaxation is abnormal. The second thing that's really important to know is that myocardial stiffness or non-compliance results in increased filling pressure. And we'll talk about that a little bit more. The third thing is that echocardiography very handily measures both myocardial relaxation, which is something that's relatively fixed, and then filling pressure, which is something that's variable. And we'll go through the parameters that tell us that in just a moment. So let's talk first about evaluating diastolic function. And I have to start with caveats because I will be the first to admit that I do not know everything about diastolic function. I know very few people who are very comfortable with it, and it is very challenging and complex. As a sonographer, the technical skill is critical. As a reviewer, either physician or sonographer, you need to make sure that the data is concordant, at least as much as possible. And you need to remember that no single parameter can really replace careful thought. This isn't something that you can just kind of do a couple things and voila, you have an answer. So you really need to organize your approach. And that's what I'm hoping to provide for you today. So the first thing that I tend to do is begin with two-dimensional echo. Look at the LV size and the systolic function. It's important to note whether the ejection fraction is normal or abnormal, because there are different parameters that we will look at in those situations. And it's also important to know if there's abnormal global longitudinal strain, because that is a part of LV systolic function. And if you have abnormal LV systolic function, you are not going to find normal diastolic function. LV wall thickness is important, and that plays into the LV mass, which we'll talk about in just a second. LA volume index is another important parameter. But then as you're looking at these things, note if there's regional wall motion abnormalities. Is there valvular disease that might confound some of the parameters you're looking at? And are there cardiac dysrhythmias? So let's talk about LV wall thickness and mass for just a moment. The main determinants of LV mass really are body size, obesity, blood pressure, and age. And what we want to do when we're doing echocardiographic measurements is to index the LV mass to the body surface area. It's very important to do that because an increased LV mass index is the equivalent of left ventricular hypertrophy. And following that logic, the presence of LV hypertrophy is an indicator of increased myocardial fibrosis, which means you will have increased LV stiffness. The LV will be less compliant. And with a less compliant LV, you end up with diastolic dysfunction and increased filling pressures. Here are the LV mass normal values. This is actually from the ASE chamber quantitation document, and you can see the LV mass is indexed. I would encourage you to use those as normals as opposed to an unindexed LV mass. And it also indicates relative wall thickness. Here is the LV mass index normals there. So let's look at the LA volume. It's important to remember that the left atrium, being a thin-walled chamber, will enlarge with chronic increase in LV filling pressures. And when you see this, it's a good predictor of the development of atrial fibrillation and long-term outcomes in various cardiac disorders. Ideally, we should be using the biplane Simpson's technique to measure the left atrial volume, and the LA volume should be indexed to body surface area. Now, I know some people are still measuring the LA dimension. The challenge with that is it's one-dimensional, essentially, and so you're not really getting a good view of the overall LA size. So we really recommend doing an LA volume index in two planes. The timing of this measurement should be in end ventricular systole, so it's just before mitral valve opening. And typically what I will do is freeze my image and then cine back and forth until it's just before the mitral valve opens. You want to trace the LA area to the level of the annulus and measure the length parallel to the long axis of the left atrium. And you're doing this in both the 4-chamber and the 2-chamber, and those lengths should be within about 5 millimeters of each other. It's really important not to foreshorten the image. I always tell my students that I don't care what the LV looks like so much. I want the LA nice and elongated and optimized. And when you are measuring the area, make sure that you do not include the pulmonary vein or the left atrial appendage if you can see it. LA volume index values, the normals were changed in 2015 to be up to 34 milliliters per meter squared. And then the chamber quantification document also provides mildly, moderately, and severely abnormal values. So let's ask one more poll question if we can. LA enlargement always means that diastolic dysfunction is present. Is that true or is that false?
29% of the audience says that's true, and 70% of the audience says that's false.
Good for the audience. Thank you, Bev.
You're welcome.
So the problem with the LA, again, thin-walled, and it can enlarge even in the absence of diastolic dysfunction because there are confounding conditions. So prolonged bradycardia, if you have anemia or a high cardiac output situation, if you have atrial dysrhythmias, you may see left atrial enlargement in the absence of diastolic dysfunction. Certainly with mitral valve disease, either stenosis or regurgitation. And then, of course, we always have the situation of athlete's heart where we see chamber enlargement in the absence of pathology. So always consider the LA volume index in the context of the other chambers, clinical status, and then also the other parameters of diastolic function. So let's continue on with the diastolic function assessment. We've looked at 2D parameters, and now we're going to continue with Doppler. Most often, we do mitral inflow. I'm going to talk just a little bit about color M mode because that's a very useful technique. Pulmonary vein flow, tissue Doppler of the annulus, and then it's important that you look at the pulmonary artery pressure because symptomatic patients with diastolic dysfunction typically have increased PA pressures. So if you're wondering if somebody's got diastolic dysfunction and they've got a normal TR velocity and a normal IVC with normal collapse, maybe not. General Doppler principles. I always harp on this with our students and fellows. Align the ultrasound beam parallel to flow. We'll talk about sample volume. You want to make sure that you have the correct size for where you're sampling and ensure proper placement. And make sure you know your knobology. Adjust the machine, the scale, the filter, and the Doppler gains. And we'll talk about these with each of these parameters. So first, let's look at mitral valve inflow. As I mentioned before, this represents the gradient between the LA and the LV. The measurements we look at most often are the E velocity, the EA ratio, and the decel time, so I'll focus on those for the most part. Now, in terms of the mitral inflow, advantages are that it's feasible and reproducible. And if you have a patient with something like dilated cardiomyopathy, reduced LVEF, the mitral velocities and filling patterns actually correlate better with LV filling pressures, functional class, and prognosis than the EF does. In terms of limitations for the E velocity, it doesn't always help us in patients with hypertrophic cardiomyopathy with a normal EF because the mitral velocities correlate poorly with LV filling pressures. It can also be very difficult to acquire this data in patients with arrhythmias. I'm pretty sure every stenographer out there has had to deal with a patient in constant bigeminy during the exam, and that makes this very, very difficult to look at. The E velocity is also directly affected by alterations in LV volumes and elastic recoil, and it is age dependent. If you recall, most patients as they age go from a normal E velocity to decrease and into an abnormal relaxation pattern. The A velocity also has limitations, and really this centers around fusion of the E and the A waves. If you have them partially fused and the mitral flow velocity at the start of atrial contraction is greater than 20 centimeters per second, it actually may falsely increase the A velocity, and then it makes the EA ratio false. It's also not applicable in A-fib or atrial flutter patients, and it is age dependent. The decel time also has limitations. Again, in a normal LVEF, it really does not relate well to the LV and diastolic pressure. And you shouldn't be measuring decel time if you have E and A wave fusion because of the inaccuracies I just discussed. The decel time also is age dependent. Typically, we see the abnormal relaxation pattern and a lengthening of the deceleration time, and it is not applicable in atrial flutter. So in terms of technical tips, for the mitral inflow, again, align the cursor parallel to flow. And I typically will use color flow, and I'll show you an example of that in just a moment. The sample volume should be at the leaflet tips, and it should be a small sample volume size. I'll show you the differences that occur when you move that sample volume in different places. You want to optimize the scale, baseline, and sweep speed, and typically use low filter and gain settings. So let's take a look here at all the different places that you could put that mitral valve sample volume and look at all the different mitral inflow patterns we get. So where do we want to be? Well, we want to be at the leaflet tips, which corresponds to D here. And you can see here we have the highest E velocity, and it's the best signal. So let's talk about how to get parallel to flow. This is a patient with a severely dilated left ventricle, and we all know how tough it is to image those patients. Often the apical window is very far lateral, but what makes it even worse is you get this laterally directed flow. And if you're trying to get a mitral inflow that comes down here with the sample volume, it will not be parallel to flow. So typically what I do then is I will redirect the transducer so that using the color flow, I can see that I'm parallel to flow. And then we end up with a nice mitral inflow signal. Talk a moment just about the Valsalva maneuver, which is one of those advanced techniques that you can use to try and sort of differentiate grade 2 diastolic dysfunction. Basically, the Valsalva is a forceful expiration against closed nose and mouth. We typically suggest 10 seconds as a minimum. And what this does physiologically is it reduces the LV preload. So if you have someone that has a pseudo-normal pattern or grade 2, then it may unmask that pattern of abnormal relaxation because it decreases the filling pressures temporarily. The problem is that the patient has to generate sufficient increase in intrathoracic pressure, and you have to keep the sample volume in the right place, and both can be very difficult. So let's take a look at what Valsalva can do for us. We have a patient here who looks like they're in a grade 3 pattern. Are they, or is it normal? If we go ahead and have them do a Valsalva, you can see that we have gone to an abnormal relaxation pattern, and then during recovery, they go back to grade 3. I wish it always worked like this. It doesn't. But let's go ahead and take a look at an example here. So this is Mayo format. Left ventricle is on the left. What I typically do is I'll go ahead and have the patient start the Valsalva maneuver while I have the 2D picture live so I can make sure that I have that sample volume right at the leaflet tips. Then I'll freeze the 2D, acquire the Doppler, and then go ahead and measure. And it may take you a couple times if you've not done Valsalva before. It takes a lot of practice both for you and for the patients. Sample volume placement really is critical. The strain phase should be at about 10 seconds or so. And then the thing to remember is that if you see an EA ratio change that's greater than 0.5, it is highly specific for increased LV filling pressures at rest. But if it's a smaller change, it doesn't mean that you have normal diastolic function or that it's a negative Valsalva. The patient may not have provided an adequate Valsalva. You may not have had the sample volume in the right place. So it's really good if very helpful if it's positive, not so helpful if it's negative. Just wanted to, as we're talking with Valsalva and mitral inflow, wanted to point out this characteristic pattern. So what's up with this? We have an E wave, we have this sort of mid-diastolic flow, and then we have an A wave. And we can actually see it here in the tissue Doppler as well. Well, this is what's called a mitral inflow L velocity. And it's during mid-diastole where we continue to have a little bit of a pressure gradient. Typically, we see it when there's markedly delayed LV relaxation in the setting of elevated LV filling pressures, and it allows for ongoing LV filling in mid-diastole and thus this L velocity. Sometimes you can see it in patients with normal diastolic function and bradycardia, but in those cases, the velocity is quite low, usually under 0.2. Color and mode. Well, only one slide on this. This is something that I tend to use sort of to augment the rest of the diastolic function exam. This really represents the rate of LV relaxation. And what ends up happening is we see this slope flattening as diastolic function deteriorates. So this top panel here is very normal diastolic function. It's very quick relaxation, and it's a very steep slope. However, as patients tend to go more into an abnormal relaxation, delayed relaxation, we see this slope flatten out. So this is something just to keep in mind when you're looking at normal versus pseudonormal filling patterns. It is most reliable in patients with a depressed ejection fraction. Pulmonary venous flow. I think this is something that not everyone does in their normal exams anymore. We still do at Mayo, for the most part. When we look at the diastolic pulmonary venous flow, we actually look at systolic flow velocity, diastolic flow velocity, atrial reversal velocity, and sometimes we'll look at the durations when we're trying to get at whether or not there's elevated left ventricular and diastolic pressure. So in the pulmonary veins, typically you're in the apical 4-chamber view. I say or thereabouts because sometimes if you angle a little bit to kind of a long axis view or tip up to a 5-chamber view, you can actually see the flow better. Turn your color on so you can see where that flow is coming in through the pulmonary valves, or pulmonary veins rather. Use zoom or res, and that'll help you see where the pulmonary veins are entering the LA. Sample volume, typically 1 to 3 millimeters. I find that larger is a little bit more useful, and you want to put that sample volume about 1 to 2 centimeters into the pulmonary vein if you can. Filters and gain should be low, and you want to optimize the baseline scale and sweep speed. And I'm going to get on my soapbox for just a moment. It doesn't help anybody if you are acquiring any kind of Doppler signal and you're only using this much of the screen. So use your screen real estate. It will help you with your measurements. Moving on to tissue Doppler. Now, we talked about how the mitral E velocity reflects LV compliance. Tissue Doppler actually looks at the velocity of the myocardial tissue rather than the blood flow, and therefore the tissue Doppler E prime velocity reflects how quickly the heart relaxes. And this is the myocardial relaxation piece. So the mitral inflow helps us with the filling pressures, and the tissue Doppler helps with the myocardial relaxation. Advantages with tissue Doppler are that it is feasible and reproducible, and the LV filling pressures really have a minimal effect on E prime in the presence of impaired LV relaxation. It's also less load dependent than conventional blood pool Doppler parameters. However, there are some limitations. You have to be careful what you're sampling. If you have a patient with coronary artery disease or regional dysfunction, if they have mitral annular calcification, surgical rings or prosthetic mitral valves, and also pericardial disease, this provides some challenges. You do need to sample at least 2 sites with precise location and adequate size of sample volume. We'll talk about that in just a slide or two. And there are different cutoff values depending on the sampling site for measurement, whether you're septal or lateral annulus. And again, this is age dependent. It will decrease with aging. So for tissue Doppler technical tips, use the apical 4-chamber view. For sample volume placement, you want to put it in the lateral or septal annulus and cover the longitudinal excursion of the tissue. So take a look at it in real time and see where you've got that sample volume. Do not measure the septal tissue Doppler if you have a septal region wall motion abnormality, MVR, AVR, myectomy, those sorts of things. And then align the cursor parallel to the motion of the annulus. This is actually a very helpful article that Jeff Hill and Richie Palma published in the Journal of the American Society of Echocardiography in 2015. And this shows a really nice example. We've got annular motion that's heading this way, but our sample volume plane is this way. So what you want to do is readjust so that the beam alignment is actually in the direction of the annular motion. As far as machine instrumentation, the sample volume size should be bigger, 5 to 10 millimeters. You're sampling tissue, and you want to make sure that you get a big enough size that you're sampling adequate tissue. And then adjust the scale, power, gain, and filter to the lowest settings. Now, I've heard some people, especially with the new requirement to evaluate diastolic function in the standards for IAC accreditation, they say, we don't have a machine that does tissue Doppler imaging. Well, you don't have to, actually, because when we first started doing tissue Doppler imaging, our machines didn't have that fun little TDI button. All you need to do is make sure that your filters, gains, and scale is down as far as possible. So the ASE document, the 2016 document, gave some nice examples of what's good and not so good about tissue Doppler. So here's an example. It's pretty nice. We're seeing a nice signal here. Here's the E prime and the A prime. In this example, the sample volume is actually in the septum, not in the annulus, so we want it down a little bit further. In this one, it's a little tough to see, so it might benefit from a little bit higher gain. And in this example, the filter is too high because we've got dead space between the baseline and the signal. So take a look at that part of the document because I think it will really help you to optimize the quality of your tissue Doppler. In terms of the diastolic mitral annular motion, for a normal heart, the lateral E prime velocity should be over 0.10 meters per second, and the septal should be over 0.07 meters per second. So when you have LV diastolic dysfunction, you have decreased LV compliance, decreased annular motion, and lower E prime velocity. So we have a nice example of a normal here, and then we have an abnormal here. In terms of the evaluation of diastolic function, when we look at the mitral inflow and annulus velocity, you can see with increasing diastolic dysfunction, we see an increase in the E velocity. However, the mitral annulus velocity is relatively preload independent. And then the EE prime is really what reflects our filling pressures. So when we look at EE prime normal values, ASE recommends using an average value of the septal and lateral tissue Doppler. And the average EE prime ratio of under 8 usually indicates normal LV filling pressures. If you have an average EE prime ratio over 14, that has high specificity for increased LV filling pressures. And then, as I mentioned before, if you're doing only septal or only lateral, there's a little bit different cutoff for the EE prime ratios. 13 for the lateral, 15 for the septal. So let's look at an example of restrictive filling in a normal 25-year-old. Restrictive, quote, unquote. We've got E velocity of about 1.2. decel time is short, but look at this tissue Doppler. It's absolutely stone cold normal. And the EE prime ratio is 7. Looking at, however, at this 48-year-old patient with ischemic cardiomyopathy, we actually see that the tissue Doppler pattern has flipped, and so we have an abnormal relaxation pattern, reversal, so to speak, here in the tissue Doppler, and the EE prime ratio is 28, which is consistent with the elevated filling pressures. So this proves my point, I think, that myocardial relaxation is abnormal in all patients with diastolic dysfunction because you do not see a normal pattern in the tissue Doppler where you do with a patient that has normal diastolic function. What about A-fib? You really can't grade diastolic function very well. The severe increase in the decel time is consistent with restrictive filling. The nice thing is you can still use tissue Doppler EE prime ratios. Those are still valid. Try to comment on filling pressures and make sure that you're averaging quite a number of the E velocities and the E prime velocities. Wanted to speak just a moment about diastolic exercise testing. If you have a patient who's dyspneic with exercise that does not have pronounced diastolic dysfunction at rest, you should consider doing some form of exercise testing and then looking at diastolic function parameters with exercise. There's a nice document in JACE that was just published this year looking at the clinical use of stress echo in non-ischemic heart disease, and that addresses some of those diastolic function parameters. And the reason we do this is because if you have normal diastolic function and you exercise, you will see a small increase in the pulmonary capillary wedge pressure, but a very good increase in cardiac index. With increasing diastolic dysfunction, you get greater increases in the pulmonary capillary wedge pressure for a very small increase in the cardiac index. So let's look at a quick case example. This is a 73-year-old lady with hypertension and exertional dyspnea, not at rest. She doesn't have ischemia and had a normal EF by resting echo. The note said this patient has delayed myocardial relaxation, but filling pressure is not increased at rest. So here's her exercise hemodynamics. This is what things look like at rest. Here's what they look like post-exercise. And look at the change in the E velocity. We're not seeing much change in the tissue Doppler, but then look at the huge increase in the tricuspid regurg velocity and therefore the PA pressure. So what's happened is that with the increase in the heart rate and with exertion, this patient develops increased LV filling pressures, which is reflected in this, the EE prime, and the TR velocity. So that can be very useful. This patient was actually referred to the cath lab for hemodynamic assessment, and at 40 watts exercise, you can see what happened to the pulmonary capillary wedge pressure and the LV diastolic pressure. So let's talk about using the new guideline. We're past talking about the tips and tricks, and now let's see if we can sort of pare this down a little bit. There are tons of diastolic function variables. It can be very hard to try and sort it all out, which is why the writing group really tried to narrow it down to just a couple things for you to look at. So in every patient, for a screening exam, you should be doing at least LV size and function, and then these 4 parameters. And these are the 4 that are highlighted in the guidelines. If you need to, you can do a comprehensive exam. That's where pulmonary veins come in. You can do Valsalva, look at A-wave durations, color and mode, and those sorts of things. But comprehensive exam really only needs to be done if you have somebody who is referred for dyspnea and the diastolic evaluation is unclear, and all symptomatic patients with normal EF, because the screening exam might not be enough. So in the document, the primary criteria for evaluation of diastolic dysfunction is average EE prime, septal E prime velocity or lateral E prime velocity, the TR velocity, and the LV volume index. And we'll go ahead and go through a couple of cases to talk about how to use this. So in patients with normal LVEF, and this is the first algorithm you should be looking at, but before we go in there, I'm going to repeat, do not forget the other clinical and echo evidence, because there could be other things going on. The 4 parameters, as I outlined them, are here. They've divided it into normal diastolic function, indeterminate, and diastolic dysfunction. Now, in the original algorithm, it says less than 50% positive, and greater than 50% positive. The way that I like to look at it is that if 0 or 1 of these 4 parameters are positive, then you have normal diastolic dysfunction. If you have 2 of them that are positive, then they're going to fall somewhere in the indeterminate. And then if you have 3 or 4 of these being positive, then you have diastolic dysfunction. And note that these are cutoffs for abnormal for each of these criteria. Let's look at a case. 68-year-old female, hyperlipidemia, had a recent increase in her LDL. She was complaining of palpitations and lightheadedness, and when she had her stress ECG, she had a 4-beat run of VT at peak exercise. So let's just take a really quick look at a couple representative images. You can see her LV size is normal. Looks like we have a good squeeze. Left atrial size looks normal, and the IVC is normal with normal inspiratory collapse. Looking at her Doppler, TR velocity is normal. We have a normal-looking mitral inflow, and then the tissue Doppler for both the lateral and the septal is quite normal as well. I'm a little suspicious about the angle of this lateral tissue Doppler, and I probably would have gone back in and rechecked that. So let's look at what we have for her. We're looking at patients with normal LVEF. The first positive finding would be if there was an average EE prime of greater than 14. Well, in our patient, it was only 5, so that one's not an issue. Septal E prime velocity less than 7. No, we had 10, so we're good there. The lateral E prime velocity is less than 10. Yeah, we're borderline, so we should probably keep an eye on that. TR velocity as a positive finding would be over 2.8, and in this patient, it was only 1.8. And then I didn't show you the LA volume index, but in our patient, it was only 23, and the cutoff is 34. So at most, we have one, let's call it a half, that might be abnormal. And as a result, this patient has normal diastolic function according to the algorithm. Looking at the other algorithm that is available in the diastolic dysfunction or diastolic function document, it's focusing on patients with depressed LVEF or normal LVEF and myocardial disease. And really the biggest thing about this is that you can typically look at mitral inflow, and that may be all you need. So if you have an EA ratio that's less than or equal to 0.8 and the E velocity is less than 50 centimeters per second, you've got normal left atrial pressure, grade 1 diastolic dysfunction. It looks like this. If the EA is greater than 2, then you know you've got grade 3 diastolic dysfunction with increased left atrial pressure. This is the section where it gets a little bit muddy, and I'm actually going to take you through a case example. There are pathways that can take you to either probably normal left atrial pressure or pathways that go to grade 2, and then you also may just not have any luck figuring it out. This is where diastolic function assessment gets tricky. So let's look at a case. This is a 70-year-old female with a history of an inferior MI. However, her calculated ejection fraction was 54%, so she has a preserved EF. She's an inferior regional wall motion abnormality, biatrial enlargement, and trivial mitral regurgitation. So taking a look at these images, you can see that she clearly has scar in the infralateral and inferior base up into the mid. She has very little mitral regurgitation. And in this two-chamber view, and again, I apologize, this is Mayo format, so this is the left side, you can see that the infarcted area. So we know she's had an infarction. We look at the tissue Doppler. This is the septal. We have sort of a reverse or an abnormal relaxation pattern here in the sense that the E prime is less than the A prime. Lateral wall, not so much. By the way, this is an absolutely fantastic alignment. And then we've got this funky kind of mitral inflow with, an L wave. So I'm immediately suspicious that we have some diastolic dysfunction here. Let's take it down the algorithm. So the mitral inflow fit into equaling 1. So we know we're in the middle here somewhere. And indeed, the EA ratio for this patient at 1 was greater than 0.8, but it was still less than 2. So we don't fall into the restrictive. We're going to be somewhere in the middle. The average EE prime was 20. And again, the cutoff for that is over 14 for the average. So that is a positive finding there. The TR velocity was only 2.6 in our patient, and the cutoff for this algorithm is greater than 2.8, so that is not a positive finding. However, the LA volume index in this patient was 44 centimeters per meter squared, and that is above the cutoff here. So 2 of the 3 of these parameters is positive, which puts us down into the grade 2 diastolic dysfunction. Now, I probably wouldn't have even needed this because of the L wave that we saw, but I wanted to illustrate how you can walk yourself through this algorithm. All right, we're going to finish up just by talking about how to report diastolic dysfunction because that is also a requirement for the new IC standards. This document is wonderful because it provides you with some options for that, and I'm just going to highlight a couple here. I think there are about 6 in the document. Now, if you are not comfortable with grading it or with grading the filling pressures, you can just say something like findings consistent with diastolic dysfunction, findings suggestive of probable diastolic dysfunction, or findings raise the possibility of diastolic dysfunction. So that's not super specific, but it at least is saying, yes, we looked at it. Another option might be to say, oh, it's normal diastolic function and filling pressure, or it's grade 1, grade 2, and grade 3, remembering that these grades work best when you have a reduced LVEF. A third option would be to report on filling pressure, increased filling pressure, normal filling pressure, or consistent with constrictive pericarditis, which is a whole other topic that I don't have time to cover today. But they have a very nice algorithm for evaluation of diastolic function in patients with constriction in the document. So I would refer you to that for further information. So let's take it all back. What's really important to know from a diastolic function perspective? Myocardial relaxation is abnormal in all patients with diastolic dysfunction. If you have diastolic dysfunction, the relaxation part is abnormal. Myocardial stiffness or noncompliance results in increased filling pressure. So if you have a stiff ventricle, you're going to have increased filling pressure because it's that push to get blood into the ventricle. And the third thing is that we are able to measure both myocardial relaxation, which is relatively fixed, and you can see that in the tissue Doppler, and filling pressure, which is variable, and that's where the mitral E velocity helps us. The other thing that's really important to know, and this is from an accreditation perspective, is that you now must evaluate LV diastolic function with a transthoracic echo through a combination of pulsed wave and tissue Doppler techniques. And if all you do is the mitral inflow and the tissue Doppler, that will fulfill that standard. But I would encourage you to also use LA volume index instead of LA dimensions and make sure that you're looking at the LV function, obviously. And then the report text must include a comment now on diastolic function, normal, abnormal, or as complicated or not complicated as you'd like to get. Okay, so we're going to go back to our poll questions, and we'll see how much you learned today. The first poll question, Bev, if you want to get ready, is myocardial relaxation is abnormal in all patients with diastolic dysfunction. And I think I hammered that point enough.
The first question is the true. The audience responded 91%, false 8%.
Okay, so then let's ask the second question. Myocardial stiffness results in what change in filling pressure? Increased, decreased, or no change? You have a stiff, non-compliant ventricle. What's going to happen with the filling pressures?
Increased, 94%, decreased, 5%, no change, 0.
Excellent. Well done. So those are the main points that I wanted to make today, and I guess now we can open it up to questions.
Okay. At this time, we will begin the Q&A session. From IAC Echo, I'd like to introduce Sandy DePetris and Ann Groves, who will be assisting with questions today. Sandy, would you like to start us off?
Sure, Kelly, thanks. So Mary, Nazmi asked for some clarification. She was wondering early on, when measuring the LA size, the LA area versus biplane, is there, you said something about doing the indexed volume?
Yes. So regardless of what method is used to measure the LA volume, area length is an option, although biplane Simpson's, I think, is a better option from my perspective, and it is what the guideline suggests. It's important to index that volume to body surface area, because what's normal in a 500-pound individual may not be the same as someone who's 90 pounds. So the LA volume index, as it says, indexes it to the body size, and it's a more accurate index to use.
Okay, Mary, Bruce asked, is it possible to do diastolic function evaluation in an exercise echo?
It is, and actually we do that in all of our exercise echoes. Typically what we'll do is, if we're looking for regional wall motion abnormalities, that's the first thing we acquire post-exercise. In addition, because we'll be looking at mitral inflow and tissue Doppler, with increased heart rate, those are typically fused. So after we've acquired our wall motion images, then we'll go back and check mitral inflow and tissue Doppler, and then we'll use those to calculate an EE prime ratio. We also check the TR velocity. And usually you can get those, if you're getting your regional wall motion analysis images acquired within 60 to 90 seconds, that's about the right time for the heart rate to have slowed down enough to acquire the mitral inflow.
Okay, next question. Richard asks, does the E prime abnormal numbers hold true for pediatric patients as well, or is that another webinar?
I think that's another webinar.
Okay.
The Diastolic Function Guideline really is for adult patients.
Okay, Frederick asks, what is the accuracy in utilizing the pulmonary vein flow to determine diastolic function grade in A-fib?
It doesn't help much at all, to be perfectly honest. So the typical pattern in atrial fibrillation for pulmonary veins is predominance of the diastolic flow. And you're going to see that in any patient with atrial fibrillation. And I don't think there's good enough data to really look at, say, the systolic versus diastolic velocities and tell us anything about diastolic dysfunction. So even in atrial fibrillation, really, I think the mitral inflow and tissue Doppler looking at EE prime is probably your best bet.
Okay, Michelle asks, in the presence of significant mitral annular calcification, how do you know where to correctly place your sample volume for diastolic dysfunction measurement?
So in those situations, depending on the severity of the mitral annular calcification, you may not be able to use tissue Doppler. If it is localized annular calcification, say it's posterior, and you're not seeing a lot of it where you're putting your tissue Doppler sample volume, then you can still use it. But if you have a heavily calcified circumferential annulus, then I would recommend not using tissue Doppler. And in those situations, the mitral inflow is likely to be elevated as well. So you are kind of out of luck in terms of determining diastolic function. In a lot of those situations with significant inflow obstruction due to mitral annular calcification, we can't answer the question, and we will usually report out indeterminate diastolic function.
Okay, Jennifer asks, if you have an E to A of 0.9, but all other parameters are normal, is that considered a grade 1 diastolic dysfunction, or is that normal function?
I wouldn't actually, unless it's in the setting of a reduced EF, I would not use a single parameter. In this situation, I would go ahead and do tissue Doppler, see what your EE prime ratio is, and then take LA volume, TR velocity, and those other things into consideration. If you remember the second algorithm, you really do just need to look at mitral inflow, but with an EA ratio of 0.9, you're going to end up somewhere in the middle, and you'll need more parameters to be able to determine whether it's a grade 1 versus a grade 2. At a 0.9, I probably wouldn't call it a grade 1. You really need to have a lower EA ratio.
Okay, Jody asks, is tissue Doppler enhanced at all with the use of contrast?
No, it is not. That's actually a really good question. The only thing where it may help is determining where the annulus is if you have really, really bad images. But because it's in the wall, as opposed to the cavity, normal contrast will not help as far as acquiring the tissue Doppler data. Now, it might be kind of interesting as I'm thinking about it with perfusion, but I think that's something that hasn't been looked at yet.
Okay, Brian asks, in the cases of A-fib, when the A wave seems to be absent, for the E to A ratio, do we put the A wave scale at 0?
That's a really good question. So in atrial fibrillation, you actually do not have an A wave. The atria is uncoordinated and is not contracting in a synchronous manner. So all you should have is E waves, and they will probably be fairly irregular. So in that situation, you cannot use EA ratio because there is no A wave in the absence of atrial contraction. So in that situation, use the EE prime ratio and look at the deceleration time. If it's very, very short and you have significant LV systolic dysfunction, then you're probably fairly safe saying that there's restrictive filling.
Okay, Payam asks, is there any difference between the equipment when assessing diastolic function? Does that play a part in the accuracy of the wave measurement?
I would
from
say
from one vendor to another. That's what he means.
From one vendor to another, no. Mm-hmm. There should not be. I know when you're talking strain, there are different algorithms that are used, but across the vendors, the pulsed wave and tissue Doppler are consistent, and so you shouldn't run into variability that way.
Okay, Eli asks, what do you do when you have severe AI, which hinders mitral valve inflow interrogation?
You do the best you can. That is a tough one, especially when the aortic regurgitation is directed toward the mitral inflow. The only thing I can do is use the color flow to see if I can optimize the mitral inflow in a plane that gets it away from the aortic regurgitation. But a lot of times that's not possible. So you do the best you can, get the sample volume where it's supposed to be, and hope that you can see the E and the A velocities well. That's a tough one.
Allison asks, so in a stress echo, with the heart rate changing, obviously, constantly, does the rate need to be at the target rate to obtain the accurate information, or how long can the heart rate drop for the assessment to still be accurate?
That's a good question. So in terms of the regionals, obviously we want to get that within 60 to 90 seconds, but for the Doppler to look at diastolic dysfunction, you have to wait until the heart rate slows enough to unfuse the E and the A waves, keeping in mind what I talked about in terms of decel time and fusion of the E and A waves. It's pretty much dependent on the patient and kind of where their heart rate goes back down. If it goes very quickly, you'll need to acquire the data sooner than you would if it takes a long time for their heart rate to return to normal. The general rule of thumb is that you get your regionals first, and then you look at the mitral inflow, and if they've separated enough that you can measure it, then you acquire it then.
Let's see. Ryan asks, since there has to be a comment in the report on diastolic dysfunction, can there simply be a comment that says you can't determine it?
Absolutely. I mentioned before that diastolic function assessment can be incredibly complex, and sometimes you just cannot come up with an answer, and there is absolutely nothing wrong with saying indeterminate if you truly can't figure it out. I think we owe it to our patients to do the best we can to look at as many parameters possible to sort out whether it is grade 1, say, versus grade 3 or whatever else. But the reality is there will be situations in which we can't answer that question, and then we need to be honest about it.
Okay. Thanks again, everyone, and a very special thank you to our presenter, Dr. Mary Bramer. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC Pro Library's website for 3 business days. In the upper left, you'll click on My Webinars, look for the title of this session, Echocardiographic Assessment of Diastolic Function. Beneath this title, you will see the link Take Evaluation. Click this link to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.